are manufacturers of specialist EPA isolate fatty acid supplements, as well as a range of therapeutic nutraceutical supplements. We're very much dedicated to education for practitioners and supporting all of our practitioners that use and recommend our products. This webinar, along with the webinar series throughout the year, really is an idea for you and for us to cover a broad range of topics and help you just to recap on previous knowledge, learn new things, and hopefully understand a little bit better about what we do here at iGenis and how some of our products and the science that we're focused on will help you and your clients throughout getting healthier and broadening your business. So without further ado, tonight's topic is looking at osteoporosis and the role specifically of diet and lifestyle in managing, preventing and treating osteoporosis. So Dr. Neela Bailey is going to kick us off with a nice overview of the science behind the musculoskeletal system and why calcium and vitamin D play such an important role in osteoporosis risk. Take it away, Nina.
Thank you, Sophie. Okay, hello everybody. Just do a quick sound check on me as well. It would be awful if you couldn't hear me. So, am I coming through loud and clear? Yes, excellent. Okay, so yes, my name is Nina Bailey, and I'm going to talk to you tonight specifically about the role of calcium and vitamin D in bone health and osteoporosis risk. So I'm going to just sort of kick off by just giving a bit of an overview of the sort of skeleton and the functions. And obviously the skeleton is best known for sort of structural support. It plays a role in the protection of the brain, for example, and the main internal organs. But it provides attachment sites also for muscles, which actually allow the movement of the limbs. But most importantly, and I guess the topic for tonight, is its role as a reservoir for calcium and also for phosphorus. And we generally kind of think of bone as a sort of non-living tissue, I guess, but it's actually living, and it's a growing tissue comprised mainly of proteins such as collagen and proteoglycans that provide a soft framework, and calcium and phosphorus, the minerals that add strength to harden the framework for rigidity and bone strength. And around 99% of the body's calcium is actually contained in the bones and teeth, with the remaining 1% found in the blood. Bone has 4 distinct cell types. We have our osteoprogenitor cells, and these are the precursors to osteoblasts, and they're induced to differentiate under the influence of a variety of growth factors. We then have our osteoblasts, and these are our bone-forming cells. Most components of the bone matrix are synthesized and secreted by osteoblasts, and they're found at the surface of the bone and generally stimulated to proliferate and differentiate as osteocytes. And these are our bone cells, responsible for manufacturing collagen and other substances that make up the bone extracellular matrix, and they can be found enclosed in the bone. And then finally we have our osteoclasts, and these are our bone resorbing cells, clast meaning to break, so the osteoclasts, literally, they break down our bones. And the whole process of sort of bone development or ossification, begins in early embryonic development around the sort of 3rd month of pregnancy, and follows through postnatal life, with bone growth continuing into early adulthood, and generally sort of peaking at about the age of around 25 years. And this is where we start to see our maximum bone mineral density. This is then followed by a long life cycle of bone remodeling and repair. And so the bone cycle goes through four main sort of areas. We have reabsorption of the osteoclast remove the bone, the mineral and the matrix, and they create an erosion cavity. And this can take around 3 to 4 weeks. This is then followed by a reversal stage in which cells prepare the bone surface for new osteoblasts to begin to build new bone. And formation, in which osteoblasts start to synthesize the matrix that replaces reabsorbed bone with new bone. And this takes a little longer, around 3 to 4 months. And then we're followed by a resting period until this whole cycle actually starts again. So bone remodeling through life is a very coordinated sequence of events which involves osteoclasts and osteoblasts, the replacement of old bone with new bone. And the normal adult skeleton, this remodeling, is based so that the level of absorption is equal to that of formation, so that the bone density remains constant. However, we do know that the number of osteoblasts, so our bone forming cells, tend to decrease with increasing age. And this affects the balance and formation and the resorption of bone tissue. And if we start losing our bone, then we lose calcium from our bones. So we've mentioned that calcium is found within the bones, and the bones are literally a reservoir for our calcium stores, with around 99% stored in the bone. Calcium has many different types of function. It's important for a variety of bodily functions, such as muscle contractions, nerve conduction, regulation of blood pressure, for example, and blood clotting. It's involved in the regulation of enzyme activity, the formation of cell membranes, and so it's incredibly important within the body. So it's not just sort of for looking after sort of bones and such. And the levels of calcium within the blood are actually incredibly important as well. And serum calcium generally doesn't deviate from its normal range because it's regulated by the interaction of two hormones, parathyroid hormone derived from the parathyroid glands, and calcitonin from the thyroid gland. And so if blood calcium levels start to fall, we get a release of parathyroid hormone, and this increases our calcium release from the bones. We get an increase of calcium uptake from the intestines and an increase in calcium reabsorption from the urine until calcium levels start to rise, and then we find that we get our normal calcium levels within the body. And then obviously the reverse, if calcium levels get too high, the thyroid releases calcitonin, calcium is taken up into the bone. There's a decrease in absorption, decrease in reabsorption from the urine, and calcium levels start to fall again. So we have this sort of constant cycle that results in sort of homeostasis for our calcium, normal calcium levels. And so the sort of maintenance of bone calcium levels is said to be a sort of dynamic phenomenon, and the input and turnover and output are all nicely balanced. So as long as our dietary supply, so our absorption from the GI tract, is adequate, and we have a nice balance of reabsorption and formation, and that our output through the urine, feces, skin, and lactation if you're pregnant are all nicely balanced, then we should have a nice balance of calcium levels within the blood and bone. We see loss of bone when calcium input doesn't fully offset the calcium output, and bone reabsorption is greater than bone formation, or if calcium losses are not offset by a rise in calcium input. And so if we start losing important calcium from the bones, we start to see a risk of osteoporosis. And osteoporosis is literally defined by the Greek porous bone, and a disease of the bones that leads to an increased risk of fracture. In osteoporosis, the bone mineral density is reduced, bone composition deteriorates, and the amount of variety of proteins within the bone is actually altered. And we see that bone breakdown is beginning to exceed that of bone formation. And we have our nice little graph here. So as we've spoken about, bone increase early years, peaking higher in men than in women, but around the age of 20 to 25, after which time calcium levels naturally started to decline, and then we have a reach here, bone mass grams in calcium about 500, and we start to reach what's called a fracture threshold. And we have a nice little picture here as well. This is a nice, healthy, porous bone, and this is our osteoporotic bone. So we're seeing lots of holes starting to be punctured in there, causing very brittle bone formation. And we can classify osteoporosis into two areas. We have the primary, which is divided into two, the most common being in women after menopause. And they start to see loss of bone when estrogen levels naturally start to fall. We then have our primary type 2, which occurs around the age of 75 and is seen in both males and females, but still at a ratio that is dominant in women, so around 2 to 1. And this is also known as senile osteoporosis. Our secondary type of osteoporosis arises from chronic medical problems, disease, or possibly the use of medications such as glucocorticoids, corticosteroids even. And so we can actually measure bone density using special X-rays, computerized tomography scans, and the information that's derived from the scans is used to estimate the strength of the bones that are scanned. And here we have our nice little scanning equipment. So the patient would lie down, keep still for about 20 minutes, and we get a full scan. And it's from this data that we then derive what is called our T-score. And the T-score reveals the status of the individual's bone density by directly comparing their bone density to the average healthy 30-year-old of the same sex. So if you're a male, you compare it to a male, female, compare it to a female. And the T-score, anywhere plus to -1, considered to be healthy. -1 to -2.5, we start to see some bone loss, and this is a term called osteopenia, and then severe or sort of osteoporosis is sort of more severe, -2.5 to 3, and then 3 and lower, we start to see severe osteoporosis. And osteoporosis manifests itself mainly in loss of height. So when you see that sort of elderly aunt and you literally say you look like you're shrinking, that's a clear sign that there's sort of bone loss going on there. We also have kyphosis and scoliosis. So we have the bending over, the sort of crouching, and scoliosis is the actual bending to the side of the spine, both indications of bone loss as well. And we also see that there's an increased risk of fracture, and this is generally around the wrist, compression fractures of the spine, and around the femoral neck of the hip. And so what's sort of causing all this? Well, we've said that bone is a living, remodeled reservoir of calcium, and that the calcium cycle depends on good quality absorption from the intestines, balance of excretion in the urine, and a balance of absorption and reabsorption from bone. Calcium levels in the blood, however, take precedence over that of bone. We've also mentioned the role of calcium in blood clotting, for example, blood pressure, contributing to brain function, muscle contraction. So it's vital that our blood levels remain at a level that can balance all the events and bits and pieces that calcium needs to play a role in. Calcium levels are under the influence of calcitonin, parathyroid hormone, but also vitamin D. And vitamin D actually plays a really crucial role in not only regulating bone levels, or healthy bone levels, through the absorption of calcium. And so if we look at vitamin D just very briefly, we have a fat-soluble vitamin that actually also acts as a pro-hormone. has individual biological functions of its own, obviously maintaining normal blood calcium and phosphate levels, but it's also involved in cell growth. It's involved in the process of differentiation, proliferation, and apoptosis, for example. It's involved in neuromuscular and immune function, and it plays a role in the inflammatory pathway. The many genes that encode proteins that regulate cell division, differentiation, and apoptosis are all modulated in part by vitamin D. So it's a very important vitamin. Generally, it's found in some food, and Sophie's going to go into a little bit of detail after I've spoken about the role of, or the sort of sources of vitamin D. But it's found in some food, but made in the body after exposure to UV lights. And here we have our little diagram showing the sun up here. And we have dehydrocholesterol present in the skin. When it comes into contact with UV light from sunshine, it's transformed into pre-vitamin D3 and then into D3. But vitamin D doesn't become active until it's literally been chemically modified by two hydroxylation steps, one occurring in the liver and then another one occurring in the kidneys. And then we have our active vitamin D3. So how does vitamin D participate in calcium uptake? Well, the absorption of calcium is transported across the epithelial cell by a process that is enhanced by a carrier protein called calbindin. Vitamin D plays a role by stimulating the expression of a number of proteins, including calbindin, which are involved in the transport of calcium from the lumen of the intestine across the epithelial cell and into the blood. And vitamin D, literally, it just speeds up the intestinal absorption of calcium, but also stimulates the absorption of phosphate and magnesium ions as well, also known to play a role in bone health. And so basically, in the absence of vitamin D, dietary calcium is poorly absorbed. And so we go back just quickly, vitamin D and bone formation. So we have our osteoblasts forming bone, osteoclast breaking up our bone. We have our parathyroid hormone that also increases the activity and increases the active or the levels of active form of vitamin D itself. So parathyroid hormone itself is involved in the production of vitamin D. And so vitamin D itself also plays a synergistic role with parathyroid hormone in stimulating osteoclast proliferation and bone resorption. So there's a whole sort of mismatch of sort of cross communication going on there. And so calcium absorption is transported across the epithelial cells by carrier molecule protein, calbindin. Vitamin D stimulates the synthesis of the epithelial calcium channels and induces the formation of the calbindin carrier protein, and we have calcium uptake. So if we have vitamin D deficiency, then we're going to have a profoundly negative impact on our calcium intake. And if we're not getting enough calcium uptake, then it's going to start disrupting the normal homeostasis of blood calcium levels, and the body will naturally start to leach the bones to get calcium levels back to a normal healthy level for normal functioning. So vitamin D, if the body has an increased need for vitamin D, then we're going to deplete the levels of vitamin D. If the body is literally unable to make enough vitamin D, so for example, if we're not going out in the sunshine or if we're not consuming vitamin D-rich foods, then we're going to get deficiencies in vitamin D. And yes, so not enough vitamin D taken in the diet. And there are several very obvious symptoms or signs of deficiency. So if you're experiencing muscle pains or muscle weakness, certainly in children if there's poor growth, skin issues, so dermatitis, eczema, acne, chronic infection, so increased inflammation, poor wound healing, poor immune function, and even conditions such as sinus infections are all strong sort of indications that there is a vitamin D deficiency. So if we can start to increase our vitamin D levels, then we'll have a positive influence on our calcium levels, which will then go towards looking after bone health and itself reducing osteoporosis risk. And so I think that's a brief sort of introduction into sort of the role of vitamin D and calcium in bone health. And I'm going to pass you over to Sophie, who's going to go into some detail on the role of diet and lifestyle on osteoporosis risk and reducing osteoporosis risk. So without further ado, I shall click over and let Sophie take over.
Thank you very much, Nina. A very informative talk as always. So as Nina's already said, I'm just going to run through the role of diet and lifestyle in managing, preventing, and in reducing ongoing problems associated with a diagnosis of osteoporosis. I'm going to look at some of the latest and not quite so recent evidence and focus on some of the other things just above and beyond calcium and vitamin D that are associated with optimizing bone health throughout the life cycle. So on the whole, the risk we're at for getting osteoporosis is generally determined by both our genetics but also early life and indeed throughout life factors such as diet and lifestyle. In terms of genetics, very little has actually changed in the last 10,000 years, but it's our environment and the diet that we eat that's changed hugely. Since the introduction of agriculture, obviously the types of food we eat are very different. We also have much more sedentary and indoor lifestyle, so we're exposed to much less sun and we sit down a lot more, so our bones aren't actually actively moving and being stressed as often as they would have been pre-agriculture. As a result, we are unfortunately seeing osteoporosis and other bone problems such as osteoarthritis, and even rickets is starting to be seen more and more commonly in Western society again. As I said, diet and lifestyle are really important throughout the life cycle in preventing bone-related disorders. But even once you've been diagnosed with a high risk or even have osteoporosis, there are still a number of things that can be done to reduce any complications and to make positive changes. So we all know that a healthy, mixed and varied diet is important throughout life, and indeed this is also the case for bone health as well. So we need to make sure that people are including a range of fruit and vegetables, but also adequate protein. Some dairy products and fish seem to play quite an important role in optimal bone health throughout the life cycle. Another thing to note when it comes to diet is the fact that healthy body weight is quite key, and in this case it's actually low body mass that seems to be linked with bone health complications. Of course, there are always things that can increase the risk of bone-related problems, so there are certain foods that we should be thinking about recommending people avoid in order to reduce any potential impact on our bone health. So the first thing we think of when it comes to diet and bone health is obviously calcium. And since agricultural farming came in, our calcium intake has scarily reduced by half, despite the fact we now so heavily associate dairy products within our diet. It's actually the reduction in vegetable matter in favour of increasing cereal intake that seems to have impacted our calcium intake quite so much. This is largely due to, as I said, the calcium content in vegetables being replaced by dairy products, which to some extent aren't actually as high as other sources of calcium and vitamin D, and also due to the increase in cereal and a reduction in high calcium and vitamin D products. So most of our calcium does seem to come from dairy products these days, and then the rest from vegetables, fortified products, and then a little bit from sun exposure, but unfortunately not enough. And the problem with calcium is that actually the bioavailability is very important, and there are a number of different factors that will impact each individual person's ability to absorb calcium. Our need for calcium actually changes throughout the life cycle. So early on in life and later life, our calcium needs are much higher than between the ages of 18 to about 55. Early on in life, we need high calcium because we're obviously forming our bones and our skeletal system, and we need to promote peak bone mineral density being achieved by around the age of 30. Later on in life, intestinal problems start to kick in, and calcium and vitamin D absorption from the diet actually reduces, but also our ability to synthesize vitamin D within the skin and the kidneys reduces as well. So it's kind of this double whammy effect that dietary sources and the sun are no longer as effective, and this is why obviously osteoporosis and osteoarthritis are associated heavily with older age. Obviously, to maximize this, we can supplement, and this has been shown more so recently in the literature after ironing out all of the creases, that supplementing calcium can be quite an effective way to achieve optimal bone health. So, some of the evidence of the use of calcium supplementation, just looking here predominantly at post-menopausal and post-55-year-old women, which seems to, for obvious reasons, be one of the key groups that are studied. It's been shown that calcium levels, calcium intake levels, are of course linked to fracture rates, but also calcium intake is linked to the amount of calcium within the bone. No surprise there. In a study of over 32,000 postmenopausal Caucasian women, it was quite significantly shown that habitual calcium intake throughout life and at that current point in time was heavily related to the risk of fracture. It's a similar story in adolescence and early life. In girls studied over a period of 18 months of supplementing with calcium and then followed up for 2 years after the supplements were ceased, we see, unsurprisingly, that both bone mineral calcium and bone mineral density are significantly better in the group that supplemented with calcium versus those that didn't, and also a number of markers of bone resorption and bone formation hormones such as parathyroid hormone, which Nina's explained, were positively influenced in the supplement group versus the control group. But the point just at the end there says that once the supplements were no longer being taken, all of the positive effects associated with supplementing calcium are essentially lost. So people's habitual calcium intake needs to be continual. You can't just supplement early in life for a couple of years or up the calcium intake of the diet and expect that to have a long-term positive effect on bone health throughout life. So studies do suggest that when we supplement with oral calcium, either by increasing that in the diet or by taking actual supplement pills, that bone resorption is actually reduced in a very short time span after taking. But because of the mixed studies and the mixed length of follow-up and whether or not it's just from the diet, whether it's just from dairy or whether it's from supplements, taking calcium alone does seem to have a very mixed message when it comes to the long-term and overall impact on bone mineral density and reducing fracture risk. The thing to note with dairy is, although it's one of our key sources of calcium, it actually includes quite high protein as well as phosphate and other enzymes and minerals that will have an influence generally positively on bone mineral density. So it might not just be the calcium that we're seeing having a benefit for our bone health. And the problem largely with calcium studies is that most of them have looked at short-term calcium supplementation or with a very short follow-up, and generally only studying people either in early or later life. So we don't really know what impact having a good supplement intake or supplementing throughout life is going to have on long-term bone health. The other thing to note about calcium supplements, and we've all heard the horror stories over recent years about the cardiovascular side effects associated with calcium, is that calcium supplements need to be really bioavailable. And this is because from person to person and between different food sources, and even the same food sources on different days and different weeks, different months, different years, will vary quite dramatically in the calcium content, and people's ability to absorb calcium will vary quite significantly. Those of us who may at some point be sensitive to lactose and choose to have lacto-free dairy products will have a reduced ability to uptake calcium, as lactose presence does help to increase calcium absorption. And also other factors within dairy will help to increase calcium absorption, for example, certain proteins and non-digestible sugars. And then in vegetable and other sources of calcium, for example, fortified cereal products, there are other dietary elements such as phytates and oxalate that will actually negatively impact our body's ability to absorb calcium. So you can start to understand why the calcium message is a little bit mixed and confusing. Now, generally, it's very well understood that when it comes to calcium, and Nina has very kindly already mentioned this, without vitamin D, it doesn't seem to matter how much calcium you throw at the body, you're not having a huge impact on the bone health. And this is obviously because of vitamin D's role in calcium metabolism and bone formation. Vitamin D is very important for both calcium and phosphate levels within the bone, but also plays an important role in muscle strength and our motor function, which will help people to remain strong and active and physical and reduce any risk of falling, which will of course reduce any increased risk of a fracture as a result of a fall. Vitamin D is only considered to be an essential nutrient in the absence of enough good quality sunlight, but for pretty much every one of us that's living in the UK, this is therefore essential because we're all supposedly, and it's very much been proven the case these days, to be deficient in vitamin D, and particularly so in winter. Largely, of course, due to our sunlight exposure being very low, because of our indoor sedentary lifestyles, but also because the wavelength of light available to us in the UK is only strong enough to produce vitamin D in the skin between April and September, when the sun is actually shining directly on us. In addition to that, the SPF levels that are so prolific in our creams, even just our general daily moisturizers seem to contain them these days, are having a big impact on the light that can actually penetrate the skin and generate vitamin D. So some of the evidence, just to really highlight the importance of vitamin D intake, in a prospective analysis of over 76,000 postmenopausal women that were consuming various different levels of vitamin D habitually, in women consuming more than 12.5 micrograms of vitamin D each day, whether from supplements or just from general dietary intake, this was shown to reduce the risk of hip fracture by nearly 40% versus those with a habitually low intake of vitamin D from all sources. And this study really highlights that point, that it doesn't matter how much calcium we're throwing at the body. If our vitamin D status is low, it's not really going to have a positive impact on our bone health. A meta-analysis carried out in 2009 showed similar results, that calcium in combination with vitamin D3 supplementation reduced fracture by a quarter and also help to significantly reduce any loss of bone mineral density associated with aging. And this is just further to things we've already known from quite a while back, that supplementation with calcium and vitamin D has actually been quite long considered to be safe, effective, and a very cheap means of preventing osteoporosis. So it's not really new news, although for some reason the message doesn't seem to be getting through to everybody. So when it comes to what should we be telling people they should be doing, generally, the literature seems to point to the use of about 1,000 milligrams or a gram of calcium each day long term for any positive therapeutic effect to be seen in prevention and reduction of osteoporosis. Of course, this amount's going to vary from person to person, and when outside of those high risk, high need age group, sort of the young and the elderly, anything between 700 and 1,000 milligrams of calcium per day from both dietary sources and supplementation, if you choose to go down that route, should suffice in optimizing bone density. Of course, the young and the post 55 to 60 should be thinking about trying to get those levels up to about 1,200 milligrams per day. And as I alluded to already, cardiovascular risk associated with supplementation is actually now no longer really considered to be a problem, providing you're supplementing with a really good natural source of highly bioavailable calcium and not these essentially chalk alternatives that are available on the market. Of course, increasing your uptake through food is a very good method to go for. Vitamin D, now this is where it gets a little bit controversial. Traditionally, it's considered that a plasma concentration of vitamin D of about 10 nanograms per mil should be enough for bone health and general health, but actually increasingly so, the science is showing that even people meeting these levels are at quite high risk of a number of health conditions as well as poor bone health. So it's now much more considered within those that actually delve into the science that 30 to 20 nanograms per mil of plasma concentration is really optimal to make sure that all of those health risks are just reduced as much as possible. And to achieve this, most people need to be supplementing just in excess of 1,000 international units, or around 250 to 300 micrograms per day in the cold, grey, autumn to winter months. And even on days in the spring and the summer when it's grey and miserable and horrendous, because the chances of us being able to actually get out and have our nice 10 minutes of safe sun exposure where we can get our face and the backs of our hands in the sun with a good wavelength of light between April to September is pretty minimal. So it does seem that most people in the UK today need to be thinking about supplementing most of the year. So that covers calcium and vitamin D, but there's actually a number of other dietary factors that are quite heavily influencing our bone health. A lot of it is to do with the other factors and proteins and vitamins and minerals that make up the bone structure, but also, as I mentioned before, just making sure that the muscles are healthy and functional so that we can prevent any falls and reduce risk of fracture as a result. Despite what we think about bones, bone mineral is actually made up of not just calcium and vitamin D, but phosphate, fluoride, magnesium, copper, zinc, nickel, barium, magnesium, and cobalt and lead, and many other things also play a big part in what makes up our bones. So there's lots of things to think about in the diet, making sure obviously people are getting a very broad range of good nutrients, high nutrient dense and good quality foods to make sure that all of the factors within the diet can be absorbed optimally. So it's not just about calcium and vitamin D. And interestingly, protein itself plays quite an important role in not just bone health, but supporting the musculoskeletal system as a whole. And as I've already said, there are a number of dietary factors that do seem to be associated with a negative impact on bone health. So when it comes to protein, unsurprisingly, it's quite important. And this is because our bone matrix is actually comprised mostly of proteins. By eating a good protein-rich diet, we can directly increase our calcium absorption as well as our insulin-like growth factor concentration within the blood. And by making sure we've got enough of this good growth hormone, we can directly increase the activity and replication of osteoblasts as well as collagen and bone-forming matrix proteins and processes. And also the presence of specific amino acids within those proteins will help to reduce activity of bone resorption cells and the processes associated with bone resorption. Lots of people commonly associate an acid-base imbalance with a high-protein diet, and this is linked to concerns with animal protein more specifically than plant protein. But much of the more recent research, as you can see in the studies quoted just below here, that actually this no longer seems to be considered an issue because high meat protein specifically intake, although it does increase calcium excretion, this is offset by an increase in absorption, and again the presence of protein increases the levels of the hormones in our blood that help with bone turnover and bone formation. And the same research group actually managed to conclude from one of their studies in 2011 that a protein intake above the recommended 0.8 grams per kilogram per day does seem to be beneficial in utilization of calcium within the body and for overall bone health in the elderly. So it seems that perhaps protein is quite an important one when it comes to the bones. Much of the recent studies have focused on whether there's a difference between animal and plant proteins, and it seems largely that total protein, inclusive of animal proteins, has a positive effect on both our bone mineral density and on fracture risk. And that supplementation of protein, so above and beyond just what we get from the diet, can have a positive impact on clinical outcome by increasing bone mineral density, but also, of course, through muscle strength and even muscle mass. And in one study carried out by a group in 2005 looking at orthopedic management strategies in hospitals with people post-osteoporotic fracture, protein supplementation, and I think in this case they actually used casein, showed that they reduced a post-fracture bone loss as well as increased muscle strength, but also reduced the medical complications and the length of hospital stay generally associated with an osteoporotic fracture. Fruit and vegetable. Obviously, we all know we should be eating these in abundance. I always try and pack in my 8 or more portions of veg a day with a couple of bits of fruit thrown in there when I can. So obviously we know these are really important, but it does seem that having a good fruit and particularly vegetable intake can directly reduce any fracture risk, largely in part due to the fact that there's quite a high content of calcium within leafy green vegetables, but also all of those other vitamins and minerals that we associate with good bone health, like zinc and magnesium, are very high in a range of vegetables as well. So getting a good vegetable intake is really going to support all of those trace minerals and elements that need to be there to help with the bone matrix formation. Of course, high fruit and veg intake is generally associated with a good nutritional status and a healthy lifestyle, but will also contribute to reducing any of the poor nutrient foods that might replace the ones that we need in order to optimize our bone health. Many people might not associate fish and omega-3s with bone health, but in the Framingham Osteoporosis study and a number of other studies, both the consumption of fish and supplementation with omega-3 fatty acids is shown to directly improve bone health and increase bone mineral density. So fish consumption, generally 3 portions of oily fish per week or more is needed to have a positive impact on bone mineral density. But also, as I said, specifically the omega-3s, EPA and DHA, can impact bone health positively by increasing calcium transport around the body so it can be absorbed and taken to the right places, but also reducing the amount that's flushed out through the urine. And also their presence seems to positively impact osteoblastogenesis, which is just the fancy word for saying our osteoblast formation and the activity of those bone forming cells as well. And interesting to note, due to EPA's potent anti-inflammatory effects, supplementing with omega-3 and specifically EPA will reduce the levels of inflammatory cytokines within the blood, which have been shown to directly impact bone mineral density, because when you've got high levels of inflammation and high levels of cytokines, these cytokines can directly sort of eat away at the bone structure and we see bone loss. But also they seem to stimulate osteoclast activity as well. So generally reducing inflammation will help to just restore and maintain a good bone health. A couple of other things that we commonly associate with bad bones and low bone density are perhaps sodium. So dietary salt has been talked about quite a lot in the science to try and understand whether or not it has a role, but it seems increasingly so that dietary salt's no longer really a major factor when it comes to osteoporosis, and actually any increase in calcium excretion that we see as a result of high salt diet will be compensated for by increased reuptake of this calcium within the kidneys. There does seem to be evidence, however, to suggest that if we've got high sodium but low potassium, this could negatively affect our bone health, because bone resorption is increased when there's low potassium, because for some reason, and I'm not quite sure the mechanism behind this, but the presence of potassium does seem to help to reduce any bone resorption associated with high sodium. But on the whole, most of the research groups looking into this do conclude that hormonal and genetic and the other dietary factors such as the presence of zinc and magnesium and even vitamin C and fiber seem to have more of an impact on bone health than salt. Phosphate. So when it comes to phosphate, as Nina's very clearly already pointed out to us, calcium phosphate is one of the key components of our bones. So if we've got low phosphate, it goes without saying that our bone mineralization is going to be suboptimal. Phosphate generally, however, is quite abundant in food, so we don't need to worry too much about deficiency, and recommending that people supplement phosphate is quite unnecessary, because you can see that last point on the slide there, actually high intakes of phosphate can affect calcium excretion as well as absorption negatively. And this can be quite important early in life, as things like phosphate are found quite high in processed food and cola drinks and all of the things that kids seem to love and sway towards, and you can't get them away from them. So it seems to be quite important that we're controlling phosphate levels rather than worrying about increasing them. Magnesium, of course, is very important, as with many things in the body, largely to do with its role in parathyroid hormone. But actually, if we've got really low magnesium status within the body, our parathyroid hormones, although they can be increased, they can increase too far to compensate. And so we see sort of a resistance to this hormone, which can cause a hypocalcemia, which means that basically our blood levels of calcium are too low, and so the bones are then being negatively affected to compensate for that, where the calcium's needed in other aspects of the body rather than just in the skeleton. So it seems therefore intuitive to increase our magnesium intake, because this will then positively correlate with bone mineral density. And both supplementing with calcium early in life and later in life has a positive effect on our bone health, whether this be just by making sure that you've got optimal magnesium within the diet, or having it as part of a good vitamin and mineral regime of supplementation. That's entirely up to your professional judgment. There are a couple of things that, again, commonly we associate with potential harm on the skeleton, caffeine being one of them, but actually, as with a similar story to sodium, the role for caffeine and coffee specifically in osteoporosis and reducing bone health does seem to be quite poor. Most of the studies that link caffeine with poor bone health are in people who are drinking 5 or more cups of coffee per day, and we're talking here sort of strong espresso based cups of coffee. So if you're somebody who loves a good cafetiere or a percolator, I wouldn't worry too much, because they don't tend to be quite as strong. But actually any negative impact does seem to be able to be offset by adding milk. So as long as you're not lactose intolerant, you're good to go with your milky coffee. Alcohol, of course, we know alcohol's bad for everything. So we need to be, obviously, if people are at high risk of osteoporosis or they do have any bone complications, then alcohol does need to be something that's considered. It's particularly toxic to our osteoblasts. It's toxic to all cells within the body, unfortunately, but osteoblast activity will be impacted. And of course, we associate high alcohol intake with a generally poor nutrient status, poor nutrient intake, because reduces appetite, makes you feel ill. It also gives you gastrointestinal symptoms, which will reduce absorption of calcium. Alongside that, then vitamin D status is going to be poor, but it also affects our sex hormones, which play an important role in bone deposition and growth of the bone. And obviously, if you're always drunk, you're probably going to fall over quite a lot. So you might not want to be doing that if you've got brittle bones. So that's enough for now about the role of various different dietary factors. Hopefully you'll be able to see that it does extend much beyond just the role of calcium and vitamin D. And obviously, as with all things health related, the more we optimize our diet, the less likely we are to suffer from all of these complications associated with aging and various different lifestyle problems. The key when it comes to lifestyle specifically is obviously exercise, because with the best diet in the world, if you're not stressing the bones, if you're not giving the body a reason to lay down bone mineral, then all of those wonderful optimized nutrients in the blood aren't necessarily going to have a huge impact on the health of the skeletal system. So it is important that we get out, we get active, and we start stressing our bones so that the bone formation and the bone turnover can continue throughout life. And quite scarily, I think, the 5-fold increase in developing a second fracture within 1 year of the first fracture really highlights that it's all about prevention of the first fracture. So an active lifestyle is associated with a lower osteoporotic risk, largely because we're functionally loading our bones and putting a positive influence on our bone mass. But we need to be exercising regularly and for a long period of time for this to have a positive change on our bone mass. The aim of exercise, of course, is in the treatment and prevention of osteoporosis is to prevent the loss but also enhance the structure of bone in preventing falls. And in order to prevent falls, we obviously want to increase muscle mass and muscle strength, but also balance and coordination to stop us from toppling over. We can achieve this with a number of different types of exercise. Weight bearing and resistance exercise specifically, because they load the bones, they put stress on the bones, and they cause adaptation and modification of the bones. But also strength and flexibility training, just to make sure that you're giving all of the muscles as much as you possibly can to protect from any falls and make sure that bones aren't going to be stressed in the wrong fashion by poor muscle function. So there's just a general recommendation there. This is taken from my own personal training. Personal, it's all personal here. These are all taken from my syllabus when I did my personal training qualification. But generally, particularly anything where you're bearing weight, so whether it's going for a walk, whether it's jumping on a trampoline, whether it's doing a weight circuit, anything that's going to stress the bones and put weight on those bones is going to have a positive impact. And doing exercise at least 3 times a week at a moderate intensity and focusing on every muscle within the body, as well as trying to build strength, build flexibility, and build stability particularly, is important. And when it comes to flexibility, we should all be stretching on a regular basis, because it really helps to maintain functionality of the body and will stop us slumping over and getting aches and pains, as well as helping to support the musculoskeletal system. And with any stretch, we should be stretching to the point where we're comfortably uncomfortable, if that makes any sense at all. It will once you try it. But of course, when it comes to exercise recommendations, if you do have a client or someone that you're working with that does want to embark on something quite new and different, then get them to work with an exercise professional originally. So that's really it from me. If there are any questions or anything you want to know, here's some good contact details. There's lots of useful information and articles on our website, so please go there, have a look. The rest of our webinar series is signed up. You've got myself and Nina's contact details there if you need to get hold of us or if you've got any specific questions. Unfortunately, I think we do have a very specific 1-hour time slot on our software this evening, so we're not going to be able to answer too many questions right now, but please do get in touch. Anything education related, there's the email address at the top there. Get in touch directly with myself if you're interested in specific training or attending any events, or even having an event come to you and us give a talk at your college or a clinic or somewhere where you work. Nina is always available for more specific and technical questions about our products specifically, so please do get in touch. Thank you once again all for coming tonight. I appreciate that lots of you have given up an hour of what is a very beautiful evening, so we're really, really grateful that you came along, and I hope to see you all very soon on future events. Have a lovely evening. Bye.